Welcome to our video on scarlet fever, necrotizing fasciitis, and Ecthyma gangrenosum. Let's get started. And here's an overview slide to keep us oriented. But let's start with scarlet fever. Now, scarlet fever is caused by strep pyogenes, but specifically the erythrogenic exotoxin, and it primarily affects children. But how does it present? Well, it actually presents in different phases. In the beginning, once there is an infection, it can take up to a week for the infection to show signs and symptoms. And this is called the incubation period. Now, once the incubation period is over, the initial phase is the acute tonsillitis phase, which presents as a sore throat. And with this, patients may have fever, headache, chills, or even abdominal pain. Okay, so there's incubation and then the initial phase. After the initial phase, the patient may progress to the exanthem phase, which is characterized by that classic scarlet-colored maculopapular rash. And that's actually where the name scarlet fever comes from. And the distribution of that scarlet rash is usually on the neck, the axillae, the upper trunk, and the groin, and it typically generalizes to the whole body within about 24 hours. Well, what happens after that exanthem phase? Well, you have the desquamation phase, and that occurs 7 to 10 days after resolution of the rash. Now, some of the classical clinical features that you may see on physical exam include the strawberry tongue, circumoral pallor, and the non-blanching sandpaper-like rash, as well as the desquamation. Here are some images that depict these various clinical sequelae that you can see with scarlet fever. Going from left to right, we first see the tongue is swollen and red, hence this is referred to as strawberry tongue. And next you can see the classic scarlet-colored maculopapular rash. And finally on the right, you can see that circumoral pallor, which is the pale area around the mouth. So you think of oral, mouth, circum as in circumferential. So you just think of this pallor around the mouth. So how do you treat it? Well, first-line management of scarlet fever is simply oral penicillin V. Now, if that's not available, or if the patient has an allergy to penicillin, you may consider alternatives like erythromycin, clindamycin, or a first-generation cephalosporin, like cephalexin. Now, you gotta treat this. It's critical, because lack of treatment of scarlet fever can lead to further complications, such as post-streptococcal glomerulonephritis. And theoretically, you can prevent that kidney injury if you treat scarlet fever. So basically, when it comes to management, let's say you're getting pimped on the wards and your attending physician says, hey, what antibiotic do you give to patients with scarlet fever? Just think penicillin. And they say like, well, they're allergic to penicillin. Then you just think, okay, you can go to one of these alternatives, but your go-to is oral penicillin V. Okay, so we just covered scarlet fever. So let's next talk about necrotizing fasciitis. As the name suggests, necrotizing fasciitis is a progressive infection of the fascia, and it's rapid. This is not a good infection. This is terrifying. And that resulting inflammation and the soft tissue edema can result in the occlusion of small blood vessels and lead to necrosis of that underlying subcutaneous tissue. So that's why it's so scary. In addition to being fast, it just destroys the tissue. And it's so important to recognize this because it can be life-threatening. And if not life-threatening, definitely life-altering. So what causes this? Well, there's actually a lot of things that can cause it. Usually it's polymicrobial, but it can be caused by strep pyogenes, Staph aureus, and Clostridium perfringens. So how's your patient going to present? Well, patients with necrotizing fasciitis will usually have a history of trauma to the area. And it makes sense that you would need a history of trauma or even a dirty surgery because something needs to penetrate pretty deep, again, that's to the fascia, to cause this infection. Okay, so history of trauma is likely, and patients will typically have some surrounding erythema and edema as well. And that makes sense because, again, we're just so deep. This infection is so deep into the tissue, and just like cellulitis, which is deep dermis, not as deep, but it's the deep dermis and the subcutaneous tissue, you're going to get that erythema and edema. And you may also hear some crackling or crepitus as those gas bubbles pop under the skin. And classically, patients will complain of pain out of proportion to clinical exam. In fact, when I was first learning about this in medical school, a classmate of mine had a relative or an acquaintance that actually had this. He just had back surgery and he showed up to a follow-up appointment to his doctor and the doctor was examining the area and the area hurt so bad, like way out of proportion to the exam. Like it doesn't look like it should hurt, but it really hurt. And that terrified the doctor. And the doctor knew that this was likely necrotizing fasciitis because of the surgery. And how did he manage it? Well, we'll get to how you manage this in a moment. But first, recognize that patients can also have systemic symptoms. And again, that's pretty logical when you think of an infection so deep in the body. And also remember that that pain can come before the systemic symptoms. So you can touch them in that area and it hurts like crazy, but they don't have a fever or anything like that. Now here's an image of advanced necrotizing fasciitis. And you can see that extensive area of necrosis in the leg. And you want to prevent this. Well, how do you diagnose it? Well, you do it clinically, but you will obtain labs like a CBC and CMP. Additionally, you're typically going to get a blood culture and a gram stain with culture of that affected deep tissue. So just think of this as being scary enough that you're not just going to say, oh, I think this is necrotizing fasciitis. We can just get by with a clinical diagnosis and treat it. It's like, no, just think of this as so serious and life-threatening that you're really not sparing any expense diagnostically because you want every bit of information you can. You want to know the exact organism. You want to make sure you target the crap out of it and destroy it. So don't hold anything back when it comes to labs. Now, imaging can also be performed, but you're not going to want to do that at the expense of treatment. Remember, this is rapidly progressing, like so fast that you can't wait to get a CT or MRI. If you do end up getting a CT or MRI for your patient, then that can reveal fascial thickening and edema and gas in the soft tissue. And that gas makes sense because we talked about the crepitus earlier. Okay, now we can finally talk about how you manage this. Now, management is immediate surgical debridement with broad spectrum antibiotics. In fact, that story that I told you about earlier, and that doctor, as soon as he thought that this patient had necrotizing fasciitis, took him to the operating room and obviously loaded him up with broad spectrum antibiotics. And these include vancomycin, you're worried about MRSA, piperacillin tazobactam to cover for most of the gram-positive and gram-negative organisms, and clindamycin. And clindamycin is really effective because of its antitoxin effects against the toxin-elaborating strains of strep and staph. So basically, you're covering everything. MRSA, gram-positive, gram-negative, and even the actual toxins. So vanc, piptazo, clindamycin. Okay, now let's wrap up by talking about Ecthyma gangrenosum. Ecthyma gangrenosum is a hemorrhagic ulcerative lesion that extends into the dermis. And it's classically caused by Pseudomonas aeruginosa. Well, what does it look like? Well, clinically, it'll start off as a painless red macule that will progress to pustules, vesicles, and even into hemorrhagic crusted ulcers. And here's an image of Ecthyma gangrenosum. You can actually see those crusted ulcers all throughout that leg. And based on all these skin infections that we've discussed up to this point, you likely guessed that the diagnosis is clinical. You can just characterize it based on how it appears. Now, typically, these patients will also be septic or critically ill, and usually the lesions will arise in the setting of bacteremia, and you have a high suspicion of Pseudomonas as the underlying organism. But keep in mind that it can actually be caused by other things. It's just Pseudomonas is the most common and it's the most classically tested. But in addition to the clinical diagnosis, you're actually going to obtain a blood culture as well as a gram stain with culture, and you're really going to want to identify the exact cause or the exact organism. So similar to necrotizing fasciitis, you're going to want to get more information from a diagnostic perspective, not just look at it and be good. Now, in order to treat Ecthyma gangrenosum, you'll typically start off with an empiric therapy that includes an anti-pseudomonal agent like piperacillin tazobactam. And that makes sense that you'd start with that because Pseudomonas is the most common causative organism. And then, of course, since you got cultures, you're going to eventually find out the exact organism so you can narrow down your antibiotic treatment to target that organism. Here's a table summarizing the various bacterial skin infections that we discussed in this lecture. And this has those high yield points, so you can actually use this to refer back to compare and contrast and just dominate your boards. And of course, since the diagnosis of any of these is so clinical and what you see, make sure you're reviewing those images that we've also included in this lecture. And with that, let's actually test you with a board style question. A 27-year-old male presents to the emergency department after falling from a rope swing at a local river and having his left leg impaled by a tree branch in the water. The patient is writhing on the bed and appears to be in excruciating pain. Vital signs show a heart rate of 112 beats per minute, respiratory rate of 21 breaths per minute, a temperature of 101.8 degrees Fahrenheit, and a blood pressure of 90/60. On physical exam, there is erythema and edema surrounding the wound, but rapidly spreading outward as well. Additionally, crepitus is noted around the wounded tissue. Which of the following options is the most valuable diagnostically? A, positive Nikolsky sign. B, deep tissue culture positive for strep pyogenes. C, history of recent hot tub use. Or D, CT showing fascial thickening. Okay, so this patient had his left leg impaled. He's in a ton of pain, and his vital signs actually are suspicious for shock. See, he's got tachycardia, which in and of itself doesn't tell you he has shock, because if you're in pain, your heart rate will likely be up. But he's also hypotensive. That's the big thing, 90/60. That is not good. And in the context of a fever, 101.8, then you're thinking he has septic shock. But what about the wound is so scary? Well, it's rapidly spreading outward, and there's crepitus. So all of that information combined really should push you towards necrotizing fasciitis. And remember that this is a clinical diagnosis, but you're really going to send out tons of labs as well. You're going to culture the blood. You might get a deep tissue culture from the wound. You're really going to want to get that stuff cooking, even though you know this is necrotizing fasciitis, because you want that information so you can tailor your antibiotics precisely. And recall that the most common organisms are strep pyogenes, Staph aureus, or Clostridium perfringens. And with that in mind, the correct answer is B, because you're going to want to get that deep tissue culture, and if it's positive for one of those organisms, then not only does it confirm your suspicion of necrotizing fasciitis, but most importantly, it tells you which organism you need to target. Now, answer choice A is incorrect because a positive Nikolsky sign is not diagnostically significant for necrotizing fasciitis. That would be more useful for differentiating bullous and non-bullous impetigo. Answer choice C is incorrect because a history of recent hot tub use is more often indicative of a Pseudomonas infection or folliculitis. Now, D is incorrect because imaging is not as valuable as a deep tissue culture when it comes to necrotizing fasciitis. In fact, we mentioned that oftentimes imaging is performed, but you really don't want that to delay any treatment, so sometimes that is skipped. But the deep tissue culture is something you're going to do every time. So again, the correct answer is B, a deep tissue culture that would be positive for strep pyogenes. And that concludes this section.